cortices, we have the thalamus, VPM, VPL, projecting up to Rotemont areas 1, 2, and 3 are generally going to be considered primary somatosensory cortex. And these are depicted in the far right diagram. So if you have input coming in, touch to your finger, you have a sense of touch coming up in the green. It's going to cross at some point, go up to thalamus and onto cortex. And then likewise, your sensation of pain is going to cross right away at the white anterior commissure, go up a separate pathway and go up to cortex. And in primary somatosensory cortex, whether you feel pain or light touch or deep pressure, that primary sensory cortex is saying, oh, here's where I'm feeling it. It's going to localize where that sensation is on your body type. And so the neurons up in here are going to have sensitivity to light touch. And as you get to areas 1 and 2, then you get a little bit more association going on, and you have more complex receptive fields, such as the limb's position and the shape of an object. When you're touching with your skin, you can determine some shape, features, and so forth as you go from 3 to 1 to 2. Then primary somatosensory cortex, if you stimulate that with an electrode, you tend to get a tingling or numbness in that contralateral part of the body. So we stimulate on the right side somatosensory cortex. I'll feel like a tingling sensation over here in my left hand somewhere. Rarely feel pain, and sometimes you can elicit a little bit of movements. If you have a lesion here, larger lesions, you can impair finer aspects of sensory sensation. It's hard to tell exactly where in what space you're being stimulated. Deficit in your sense of position and movement of affected parts, but does not abolish your tactile sensation of pain or for pain. So in general, S1, good for localizing pain or touch, but if you want to say the unpleasantness quality of pain, that tends to be other cortical areas. It's more widely distributed throughout the brain. Pain's more difficult to deal with. Okay. Oh, and with regard to S2 on our second slide here, so our secondary somatosensory cortices, mostly located up here along the parietal operculum. Operculum just means lid. Here's the parietal cortex, and here's the lid overlying that sylvian fissure, parietal operculum. And it too has a somatotopic map. So in the lower right diagram, again, we had with S1, we had the lower limb on the mesial surface, then thorax, neck, shoulder, hand. Here we have fingers, and then we go to tongue, and the face is out here. And then with S2, it goes the other direction, face to arm to leg as you go back lateral to medial up into that parietal operculum. So it too has a somatotopic map. And the receptive fields in here, if you go with an electrode and try to map that out in a person, is going to be more bilateral, touch to symmetrical places, sites to activate them, say on both of your index fingers. And with this fun demo, for those of you who happen to have some coins in your pockets, I have here various coins, and you can try this with a friend at home, or if you're with someone in the room there, is to put a coin in your hand. I'm going to put this one right here in my hand, and without looking, tactile feel, what is that coin? Is that a nickel? No. Is that a silver dollar? No, I don't think so. Quarter. I can figure out what that is. And that's using stereognosis, where you are grasping the coin, tactile, palpating it, putting together what is that three-dimensional object. And with lesions that take out S2, you can then lead to astereognosis, or that inability to identify what is this object based on sense of touch. All right, so the question comes up as to why on earth does this, here we have the homunculi, Milton and Freddie here, the somatosensory cortex and the motor cortex models. A question often comes up, why does it go leg to foot to hand and right next to face? Because I mean, your face and your hand are pretty darn far apart anatomically.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.